Be gentle with me, please, because I'm new to all this, so, you know.
What you did this morning, so you can't count anymore.
There you go. Very quick introduction. This is Dr. Mike Patel. He's a consultant in diabetes. Dr. Patel's worked as a consultant in diabetes and acute medicine at University Hospital Southampton since 2008. With a keen interest in diabetes education, he also contributes to the medical undergraduate and postgraduate diabetes training curriculum, as well as regularly delivering diabetes education sessions to patients, public and other healthcare professionals in primary and secondary care. He co-developed MicroGuide Diabetes, yeah, there you go, a smartphone app to help healthcare professionals managing people with diabetes. He also co-developed Type 1, a diabetes healthcare, Type 1, a diabetes comic book series, which you may have seen in the hall, and in 2015, he was named as the Quality in Care Awards Outstanding Educator in Diabetes. In 2020, he was co-winner of the Quality in Care Awards Diabetes Education Programs for Understanding Insulin, an online insulin course that is freely available globally.
Thank you very much. Thank you for making the time to come along to hear me speak today. So young Mark's going to kindly change the slides as we go through. So my brief is called From HbA1c to ZZZ. I'll unpick the title as I go through. Essentially here to update you and talk to you about planning for hospital admission if you have diabetes. I'll start off by saying this is not meant to be a political session. I sincerely appreciate, I work in the healthcare system, how under pressure healthcare is. We all know this. So I'm hoping today is not a chance to sort of tell me off, have a go at me about how hard it is at your local hospital. Please don't. But my brief is to hopefully find ways that are positive that help you live well with diabetes as you plan for hospital admission, which can happen regardless of how long the wait might be, that sort of thing. I hope that's okay. All right, so thank you for understanding and obliging. So next slide, please, Mark.
Fail.
Epic fail?
Epic fail. Oh, there we go. Try that.
Lovely. All right.
There we go.
So you've already heard who I am. So I work in Southampton. I'm very passionate, enthusiastic and interested in supporting diabetes care in hospitals. So to paint you a picture, Southampton has about 1,100 beds. On any given day, we host approximately 250 patients with diabetes a day in our hospital. So I can't see everybody. Or my very small team can't see everybody. So we do our best to ensure that our patients are informed before they come in of what sort of things to think about, which I'll touch on today. And we also do our very best to educate other teams, as Mark was alluding to, as part of our offering to support diabetes care for our patients. So my skill set, as I said, I've been working in this area for quite a long time, and I'm increasingly keen, as I'm not getting any younger, unfortunately, to make sure that what I know about supporting diabetes care is shared at scale across audiences like yourselves, as I said, with colleagues, other patients, etc. So I try and do. I network with national friends all the time to share ideas about what works somewhere else. We try and use a version of that in one hospital. Might always work somewhere else, but we do our best to offer similar approaches based on each hospital's culture and perspective and political leanings, if you like. Thank you. Next slide. So what will I cover in the next, 30, 40 minutes or so, is a brief overview of diabetes in hospital. We'll talk about the impact of illness and hospital-based interventions when you're not very well in the body, ideas how you can support self-care before being admitted, and perhaps some resources and ideas of things to take with you when you do go to hospital that you may not have thought about might be important, as patients do get caught unawares of, oh, I wish I brought in X, Y, and Z. So I'll go through the X, Y, and Z a bit later. All right? Thank you. Next slide. Right, so in hospital, let's talk about that first. Thank you, Mark. Next slide. Okay, to paint a picture, as I mentioned briefly earlier, across the UK, in any UK hospital, give or take, 20-25% of all the adult patients in hospital on any given day have diabetes. Fast forward 5-10 years, this could be 30-35% if the predictions are right. They don't have to be, but it could be a thing to consider. The vast majority of patients in any UK hospital will not be under immediate direct care of a diabetes team. They will rely on colleagues, like myself, who are diabetes trained, to support the other teams and offer advice, create guidelines, that sort of thing. It's very rare for a hospital to have weekend diabetes services. It's something that's being pushed for, but as I mentioned earlier, we know politically there's challenges in funding and resources. It's not always possible to have a 7-day service. We don't have one in Southampton, but we like to feel that our processes we have in place ensure that if somebody with diabetes, God forbid, is admitted on a weekend, there's no reason why they can't be offered a very good standard of care by the teams that are on duty following the guidance that's available on the day, shall we say. And touch wood, yes, things don't always go to plan, but there haven't been any major clangers on the weekends when we've not been there. So let's hopefully give those in Southampton catchment some reassurance, for example. I can definitely tell you no hospital's got a nighttime diabetes team, as far as I know. That does not exist across the UK, as far as I'm aware. We do know also from research and audits and things that if you're admitted for any reason and you have diabetes, be it pneumonia or an operation or a broken bone, regardless of the reason, just by virtue of having diabetes can infect and increase your length of stay in hospital, which is not good for anybody, but there's things I'll talk through to try and mitigate that potential risk, for example. And of course, we know that diabetes care is not always bulletproof. We'll put our hands up. We all know we can all do better, and there's always something, a process or a procedure, a documentation of something that can be done better. And unfortunately, if things don't always go to plan, it risks patients' things being delayed, potentially patients being harmed, unfortunately. So it's always important, if you go in there as a patient with diabetes, you live with this every day. It's important you are vocal and feel listened to. If you don't feel listened to, please shout louder. It's really important you do feel listened to, because you live with this, you know what your insulins, medications are, in more detail perhaps than healthcare workers looking after you. So it's important you do feel able and confident to speak up and not feel, dictated to, which is a strong term, but I'm the medical person, you're the patient, you will do what I say. It should not be like that. It should be a cross-talk, mutual appreciation of what we're trying to both achieve for your well-being, for example. All right, we good so far? Perfect, thank you. Next slide, please. So let's touch on some basic biology on a Saturday afternoon, nearly afternoon. Nothing too complicated. Thank you, Mark. Yeah, right, this is hopefully the sort of baseline of everything. We all need insulin in our bloodstream to be working properly. Without insulin working properly, being it deficient, as in type 1 diabetes, or your body being resistant to it in type 2 diabetes, if its effect is not improved, it means that the body cannot take up glucose from the fuel, the food you eat, in your blood to be used as petrol. Therefore, various bad things can happen because of that, which in a hospital setting means that for days, hours or weeks of high sugars, you're in a default position where you're sitting there with persistent high blood glucose, which is not good for reasons I'll touch on, which you already know, I'm sure, but I'll come back to that. So ultimately, we need insulin to be working at a level that's appropriate for you, whatever dose it might be, whatever pills you might need. Ultimately, they're trying to ensure that the level of insulin working for you is helping to keep sugar levels in a place that's safe. Okay? Next slide, please. Fight or flight's a term of phrase you may have heard of from evolutionary terms. Essentially, what it talks about is that the stress of modern life, everything triggers various hormonal chemical reactions in your body. You produce stress hormones such as cortisol and adrenaline. These hormones generally do various things in your body. They prepare you for states of fight or flight. They are going to hit your liver, metaphorically speaking, and promote a glucose dump into your bloodstream to give you energy, to give you glucose to energy to fight for these fight or flight situations. If you don't have diabetes, magically, you'll produce enough insulin to get the sugar levels to not too high. If you have diabetes, of course, that may be difficult to do. It won't happen naturally, of course. It may require medical intervention, medicines, insulins, tablets to help achieve that. It's remembering that high and low sugar levels can happen in results of stress, even without food. This is a misconception people do believe. I didn't eat anything sweet, my sugar levels are really high. That, don't believe you probably didn't, but the stress of illness or whatever can trigger these hormones which can raise sugar levels with no sugary food in sight. It can happen. Equally, if you're ill, not very well, not eating properly, nauseous, etc., throwing up, severe diarrhea, and food goes straight through you or out of you, if the medicine is still there, but the food energy isn't still there, your sugars can go low. So you can see how it can happen both ways, can happen, okay? And in hospital and beyond, if you have persistent high sugar levels, in certain situations, if your sugars run high, and as I said earlier, that means you might be short of insulin, it's particularly high stakes in these situations if you have type 1 diabetes. If you have something called type 3C diabetes, this is where your pancreas is not working for different reasons, such as pancreatitis, pancreatic cancer, God forbid, other cystic fibrosis, it means you might be on insulin. And if sugars go high, you risk your blood becoming acidic and becoming unwell. There's a newer class of diabetes pills called Flozins. Some of you may have heard of these or beyond them. Very good pills in well patients for hearts, kidneys and glucose. If you're sick, dehydrated, unwell, not eating enough sugary-based, carb-based food, you risk developing ketoacidosis. So these are risky areas in diabetes. Unfortunately, with education and knowledge and training, the risk of developing DKA, thankfully, can be minimised and reduced. Okay? And unfortunately, we do know, sadly, in the UK, through various knowledge gaps and problems, we know patients have gone into DKA on the wards in hospital, which is not great. I hold my hand up to that, as my medical friends in the room would as well. But no one wants that, of course not. It happens in Southampton probably 5-10 times a year, I would say, give or take. And the most common place it happens is on surgical wards after operations, because somebody sadly has not taken oversight of the fact that Mrs. Smith's blood sugar was running sky high, despite not eating. Oh well, let's just keep an eye on it. But they didn't realise the insulin dose needs to be matched for the high sugar levels, and consequently, the patient develops ketoacidosis. That's one example. There are unfortunately other ways in which it can happen as well. So by you guys being vocal, saying I need my insulin, etc., my sugars are high, that can really help focus the mind of somebody busy under pressure, perhaps thinking it's a bit of high sugar, it's going to be all right. No, it's not going to be all right potentially. So do speak up and be vocal if you're worried. Okay? And again, if you're ill and not very well and you get dehydrated, hence, as I said earlier, that does increase your risk of developing ketoacidosis. And another awful situation called HHS, the posh medical name is hyperosmolar hyperglycemic state. If you get sick, ill, dehydrated in type 2 diabetes chiefly, you risk developing this condition whereby you get very drowsy, astronomically high sugar levels, very unwell, very dehydrated. It needs urgent prompt attention to correct the fluid state, and the body salt levels are also quite deranged as well as a consequence. Okay? You can develop DKA over a few hours, unfortunately, 12 to 24 hours. HHS will take longer to develop, give or take a few days, if not maybe a couple of weeks to develop HHS compared to DKA. But thankfully, unbelievably, a few years ago, locally, there were a couple of patients who developed HHS in hospital, which is unbelievable, but it happened for various reasons. But touch wood, for better knowledge and education in Southampton, it's not happened for a good while now. But it can still happen anywhere, so just be vigilant if people are not very well with high sugar levels, be vocal. Okay? Next slide, please, Mark. And a further consequence of high sugars in the context of being ill is that high glucose can impede and impair your immune system to the tune of 90%. So your ability to fight infections and bugs is compromised if you have persistent high blood sugar levels. It can also delay wound healing, which after a major surgery you can see that can be a problem. You've got patients who had bypass surgery, for example, and if that wound gets infected, you can imagine, can't you? It's very high stakes in terms of risk of harm. Some patients go back to theatre, for example, they're in hospital for longer, it's very miserable. You get the idea, so it's a risk. If you're sick and ill, your body's response to insulin may be different in the sense that you might need sometimes doubling or tripling your usual insulin dose. Don't be alarmed, it is just what it is. If your body's under stress and sugar levels go sky high, you need more insulin. Sometimes patients come to hospital on tablets. We may switch them across to insulin short term, perhaps, because that works quicker than you can't just up the pill, it's not going to work. We switch them to insulin, that does happen sometimes. Either short term, if not longer as well. They may go home on insulin, depends on the individual's situation. So don't be alarmed if that happens. If the team looking after you feel that's in your best interest, they should be discussing it with you to take your view on it, and you can make a decision if you think it's for you or not. Generally speaking, we advocate quite aggressively. If we feel somebody needs insulin, we can't force it on people, but we'll definitely make a case to why we feel, rather than just giving yourself more metformin, you actually need some insulin to get this down for a few weeks after the operation, for example. Okay? We know that, where are we? So being in hospital, if you're sick, we know the food choice in hospital, I get it, I'm not here to say, not here to be political. It's a catering company often that's sourcing the foods, and we know this presents some challenges, and the right things being available to you for what you need. It's a work in progress nationally. Not quite there yet, I know, but it's on more and more radars to think about. You know, if Costa, the coffee shop, other ones are available, can present their their glucose content of whatever they're offering in the coffee shop, the hospital's going to verge on the same thing. But hopefully over time we will get there. It's just a matter of just writing it out. And as you can expect from all of these things at home, if you're sick, ill and unwell with high sugars, that potentially can increase your risk of needing to be hospitalised for whatever reason. And again, persistent high sugars make you anxious, make you stressed, make you worried. And that glucose that's high in your bloodstream, not being used as petrol, you're going to feel more tired and washed out. So it's important to get these things looked at if you're worried. Next slide, please. So thankfully, as a resource, again, shameless plug alert, something I did, which was, worked for the charity for a number of years. So myself, my lead nurse, Paula, a little while ago, updated our sick day leaflet that's available to you. It's in the main hall. I think there's hard copies there, or nearby the main hall, which hopefully walks through some of the things you can do at home to stay less ill, if you like, when you are ill with diabetes. A few simple interventions that can make you feel better, hopefully. There's hard copies there, or I believe it's also can be downloaded from the website from the charity. So you've got two places to find the information, to have a look, have it to hand, share it with your family and friends. Everyone knows exactly what John needs to be doing. If John is too ill to tell you, you can read it and walk through, oh, okay, John needs a bit of this, a bit of that. You can have a look at it. All right? Thank you. Next slide. So if you do get admitted unexpectedly, you should, I guess, expect the unexpected, okay? Not everyone knows they're going in. If you get poorly on a Monday morning and find yourself in the ward on Monday afternoon, you could have been completely out of your control. You were too ill to stay at home, decision was taken, the ambulance was called, you went in, there you are. So what sort of things matter in hospital from my perspective that I feel would help you as well? Making sure that you and your family have told the staff on the ward you have diabetes. I know it sounds really obvious, and again, I can only speak for my hospital. Touch wood, Southampton's pretty good at knowing who's got diabetes. I'm not aware of a case of somebody being missed, not monitored, because no one knew they had diabetes. It didn't happen in Southampton. But I can't promise it's not going to happen anywhere else, but just be aware of the need to make sure. You do know my husband and my wife has got diabetes, just make sure it's said. Better it's said more than once than not at all, I would suggest. Okay? Because obviously, importantly, if you've got high sugars, you do know you know my husband John's got type 1 diabetes. Are we happy he's not got DKA? You know, just have that opening gambit is absolutely fine. And then they can check the ketones and make sure and start treatment. It's important not to make any assumptions. You may need to be fasted, and as I touched on, fasting is not without risk in diabetes. It requires giving somebody a drip with fluid, insulin sometimes, and it can cause nutritional wobbles and sugar wobbles, but sugar levels are never going to be a straight line, we know this. There's a bandwidth we aim for. So never worry, if it's going to be jumping up and down, it will jump up and down, but we just need to make sure the bandwidth of jumping is not too high and not too low. There will never be a flat line. I can tell you that much for free. So the fluids you might need, as I said, sorry to repeat it, you might need IV fluids intravenously with or without insulin. You could deliver intravenously as well, and sometimes concurrently by jab as well in certain situations. Sweet treatments refer to the fact that though hospital teams are trying to help you get better, there's some interventions we do for patients that unfortunately can make sugar levels transiently a bit worse. So some patients, for example, require the use of artificial feeds, nasogastric tubes or tummy tubes, high energy calorie feeds being delivered contain glucose, and that can also cause some sugary wobbles. And in a number of patients we look after, so in Southampton again, those patients, let's say for example, are really well held on diabetes pills at home, because of what they're being given in hospital, those pills are not going to be effective. They may therefore need to be switched to insulin for a period of time, whilst the feed is being used, for example, but it's going to vary in different people. Kidney dialysis can cause chaos as well with sugar levels. Using the big one is steroids. Steroid tablets, steroid injections are the big hitters. Steroid creams are generally okay, but steroid tablets and the injections are the ones that really tend to cause a bit of sugary chaos by making your body more resistant to the effects of insulin. Okay? And surgery, of course, yeah. The stress of surgery. Surgery is a fight or flight situation. Your body's going to be in metabolic meltdown after an operation. You're going to be spitting out adrenaline, cortisol, dumping liver to dump more sugar in your bloodstream. Sugars can be, all over the place. It's a stressful situation for your body to have to deal with. And therefore, it might be the case that on the ward, you might be somebody at home who's only looked after by the practice nurse for diabetes and don't see any specialists normally, and that's fine. But if your situation is complicated in hospital, you may need review by a diabetes team, and that's what my team do on request across the hospital. We get 20 or 30 referrals a day for various reasons to go and see somebody with diabetes, try and optimise things, be it a change in treatment, changing dose, start insulin, whatever it might be. That's what my team's role is, to go and have a look and see what we can help with. And we obviously do our best to educate other teams to make sure they know when to call for us. rather than just trying to write it out or ignore it. Let us know there's a problem. And one of those key messages in the title of the talk is HbA1c. For those that aren't familiar, HbA1c is the blood test we do every few months. It reflects the previous 3 months' sugar levels in your bloodstream, and provide the blood test results accurate, if the number is above a certain threshold, it may suggest either the person perhaps wasn't taking pills as advised as they should have been, for whatever reason, or it might simply reflect the fact that this person's pills no longer doing the job and a therapy change is needed. It's a useful blood test to do, so that's what it's for when it's done. And increasingly, it's being done before planned operations, which I'll talk about in a minute, to ensure that someone is in the best diabetes situation they can be before planned surgery. Okay? Next slide. Yeah, okay. So it's making sure that you feel confident in the team looking after you in the hospital. From the minute you go to a clinic and be told, yes, Mr. Jones, Mr. Patel, you need an operation, it's that moment there, if you have the presence of mind to ask the question, I've got diabetes, should I be concerned? What provisions will there be for me? The person who talked to you should have the answers. That's a good place to raise that question, I would suggest. And it's making sure that the hospital you're going into is diabetes fit. Like I said, I can't speak for other centres, but we do our best in Southampton. That's not me, by the way, in case you're wondering. But we do our best to make sure we support our patients best we can. Next slide, please. Okay, so we're all after sweet success, of course we are, no pun intended. Beating the stress of surgery, stop it, I'll stop there, sorry, okay. Now, surgery is complicated. Small operations, big operations have different effects on different people. As with fight or flight, it is a stressful chemical situation that we induced in your body after an operation. So I mentioned earlier a few of these things already, but these are risks particularly after operations as well. You may clock sugars going up, the stress of the intervention, low, the person not eating properly, feeling sick, being sick, etc. can cause the lows. And these can happen kind of, across the whole time you're in hospital. But like I said, our job is to make sure the bandwidth is not too high and not too low, and definitely trying to avoid any sugar levels under 4 causing what's known as hypoglycemia, of course. Obviously, we're keen to make sure that risk of infections, that high sugars and wound healing problems is mitigated by ensuring we advise teams to ensure that the person's sugar levels are being kept in the nationally recommended bandwidth. We definitely do not want any patients developing these awful emergency situations of DK and HHS. It does happen, sadly, and it shouldn't. It's just a constant stream in Southampton for us to educate the teams involved about what went wrong, what they do differently next time, etc. It's education, education, education. Some people have anaesthetic, well, you all have anaesthetic for surgery, of course you do, and the drugs that are used, sometimes different parameters are monitored, blood pressures, pulses can jump up and down for different reasons, with sedation, if you're put to sleep, an operation, those sorts of things can cause indirectly, can wobble the sugar levels as well. And we know that if you're not eating and drinking and you're fasted, yes, of course, you're receiving some fluids. Having fluids intravenously for days on end is not without risk in terms of causing some internal body salt imbalance, if you like. So those things need monitoring regularly. Kidney wobbles reflects the fact that if somebody comes to hospital with known to have kidney disease, let's say, if your kidney function is less than 40% of what it should be, it means a couple of things. It means making sure that the diabetes drugs you're on or other drugs are still appropriate to use in that situation, because lots of medications cannot be used if somebody has kidney impairment because they're not licensed for use. And it also means that things like insulin, if your kidney function is 35-40% or less, your body's ability to break down insulin and clear it, both what you make naturally and as well as being administered, is slowed down. So you have more risk of going low with reduced kidney function. And sometimes, depending on what you've had done to you, if for whatever reason the blood pressure dropped, let's say, the heart pumped a bit more slowly, and the kidneys got a bit less than their usual 25% of blood supply per heartbeat for whatever reason, it means the kidney function might take a bit of a hit and dip a bit, which means that risk of low sugars may happen transiently, for example. And gastric wobbles refers to the fact that if somebody's had tummy surgery or other operations or anaesthetics, and certain pain management as well, some of the therapies that use in pain management can also delay the tummy's movement in that direction. So you might still feel a bit sick and food goes in that direction, unfortunately. So it can cause nausea, vomiting. So you can see as a package of things, all out of your control, that's to say out of your control, stuff in hospital, the body's reaction to operation can cause some bother from a diabetes perspective. And what's great for me in my job is that for the last 10, 15 years or so, this area has courted massive interest, lots of research, lots of studies in trying to inform best practice to mitigate risk. There are various national bodies, such as the JPDS, my good friend Catherine sitting here on the national group of specialists who look to create guidance for hospital teams to follow for certain hospital situations to give you assurance. The team looking after you is not just kind of, yeah, we're giving that drug, yeah, we're giving that, you know. They're following established best practice for what they should be offering you. Okay? Next slide, please. So if you know you're going to an operation, as I mentioned, the likely steps will be going to your GP, with a problem, whatever it might be. GP says, yeah, okay, let's ask a specialist. And I appreciate waiting lists are long, and I'm sorry about that. When you do get to a specialist, being prepared for it is really important. You've got time to prepare your questions, your headspace, your thoughts, jot things down before you go. It's likely in this situation you'll see a surgeon, let's say, yeah, I agree, Mr. Desai, need an operation, whatever it might be. That's the sort of conversation conclusion. Now, as I touched on in the title of the talk, HbA1c, this blood test that gives you a 3-month look back, nationally, the aspiration is that for someone having planned surgery, this number sits as close to 69 millimoles per mole as possible. It's a very pragmatic judgment that's been made nationally around what level of glucose control would we accept in terms of managing not going too high or too low to proceed to operate on somebody knowing that the stress of surgery could cause all the stuff I just talked about in somebody. Does that make sense? So we try to make sure we try and minimise the risk as much as we can from a diabetes perspective. So we're trying to do that by ensuring that if you achieve that level of HbA1c or close to that in the preceding few months before your surgery, you can hopefully do a massive amount of help to minimise the impact of all those wobbly things I talked about on your sugar levels after the surgery. And the worry is that nationally, there are some surgical teams and anaesthetists who may not wish to proceed if that number is above 69, for very good reason. Because they're going to worry that if I do this to Mr. Jones or Mr. Smith, he's 100, he's going to become really unstuck after surgery and potentially come to harm. So you can see why people might want to defer, not say no to an operation, but postpone, defer it until such time that the number comes down to a better place. That's why that's done. So it will be hard, maybe hard for some people to hear, what do you mean my operation is cancelled? I don't believe it. I've been waiting for months, which I get. It's a very real frustration, but we're trying to balance the risk of that weight, of that number, with the benefit from the outcome of a good operation, if that makes sense. So there's always something we can all do, which I'll come to in a minute, to make sure that waiting time is used really effectively, as well as possible. Okay? And that's a national number. It's used in most hospital settings, that sort of ballpark, that aimed aspirational target of HbA1c. The slight exception to that rule will be cancer surgery. And of course, no one wants to get cancer, but equally, there is morally and ethically in Southampton, we will not defer somebody's operation who's got cancer. Because as you can imagine, the whole point of cancer, you want to get on with it and get it out. Of course you do. Accepting that that is a risk to proceed at that stage, but if the benefit that's perceived outweighs the risk, you would proceed in that context with a high HbA1c for cancer surgery, knowing that this person's at risk, meaning that my team, for example, we notified that Mr. Jones is coming in next week for his bowel cancer operation. We go and see immediately afterwards in an effort to really do our level best to minimise the impact of high sugars after surgery. That's the best compromise we can offer in that situation. So yes, it's risky, but they want to get on with it. And like I said, as long as the right safety netting is in place around that, so these are questions you can ask your team when you go and see a surgeon, etc. about what's my aftercare going to involve from a diabetes perspective. Please ask those questions. You're expected to be informed. It's your body, it's your decision, so please ask. And again, if your surgeon's not sure, again, the next question perhaps will be asking, is there a process by which your diabetes team come and see me? Just ask those questions. These are guidelines. Just do ask. These are relevant, good things to ask to come across as informed about your situation. It's important. Okay? Next slide, please. So if you know you're going, what should happen next? At some point along the way, it could be a few weeks before the operation. It might be a few days. It depends what you're having and where and how long waiting lists are. But again, it sounds like a broken record, but please make sure that person has documented you have diabetes, or bonus points, the type of diabetes you have, especially type 1. Because what we don't want is missed or delayed insulin if somebody's got type 1 diabetes. The stakes are much higher than if that was type 2 diabetes. What is also likely is that following national guidelines, there's lots of protocols that we use, some of your medications should be suspended entirely in the day or two before the operation and the morning of, and in the days afterwards, because they're going to be deemed to be causing more harm than benefit in that situation. So you should be offered some summary guidance of what to do with your meds, which ones you suspend, which ones you reduce, insulin doses, what you do with those. It should all be clearly communicated to you before the operation, so you turn up on the day having done the right thing, because there's nothing worse. Can you imagine waiting 6 months, you took this drug, oh, you weren't supposed to, oh, it's cancelling now. You can imagine how frustrating that is for everybody. So we get this right the first time. It's mission critical to be clear on that and be given written guidance so you know exactly what you should be doing. Because by being fasted, if you carry on with some of these drugs and you're going to be fasted, you can see the problem, can't you? Like I said earlier, you take the medication, no food, you'll go low, yeah? Which is risky, of course it is, so no one wants that for anybody. I appreciate this is a type 2 room, but should anyone be in the room or have no one with type 1 who's on the insulin pump, that's a very specialist thing to talk about, insulin pumps. I'm not doing it today, but just to say, in that situation, the person using the insulin pump should tell their insulin pump team, hi team, just to say, in a couple of weeks I'm going in for an operation, what do I need to do with my insulin pump? That is the team that will give the pump guidance specifically for you, because your pump settings will be individual to you. You can give some generic guidance as an assessment team possibly, but it's best coming from the pump team who can then share that plan with the assessment team on your behalf. That can be done, as we do locally in our centre in Southampton, so that's how we tend to do it. In touch wood, no major wobbles as far as I know. Okay, so that's out there. Thank you, Mark. Okay, that's a bit of background, hospitals. That paints a bit of a picture for you to think about what could happen, what might not happen, what would never happen, hopefully. You can give you some idea of the sort of things that can impact on sugar levels. Let's touch on some stuff you can do at home. Next slide, please, Mark. Okay, it's a busy slide. So if you've got days, if you've got weeks and months before your operation, and you might feel frustrated having to wait so long in pain and discomfort, this is still me trying to be glass half full and advocate this is useful time to get in front of your diabetes as much as possible. That's realistically possible for you. There's a turn of phrase, you may have heard of this, called prehabilitation. Have you heard of this? There's a big push nationally on this thing called prehabilitation, where, as the name implies, it's optimising people physically before planned surgery, in the hope that by doing that, this person is as good physical nick as they can be. It's like training for a marathon, shall we say. You train, you don't just get up and go for a run, you don't just get up and run 26 miles without training. I wouldn't have thought. I wouldn't, I'm sure you would. It requires planning, it requires training, it requires support, etc. And a strategy, okay? So these are some of the themes that we talk about, recommending patients think about doing, if not already, in the months and weeks preceding planned surgery. So for example, if you're somebody who checks sugar levels at home and the data is concerning, get some support, get it looked at. Don't just say, oh, I'll leave it, it's always high, I can't bother, I'll leave. That's the wrong thing to do. Because the worry is you'll wait and wait and wait, get to hospital, anaesthetist will say, your sugar's 25, can't operate. Yeah, so always please try and get in front of it as much as you can. If you were told your HbA1c is high, again, that's a red flag to try and get it down before the operation, but there's no point repeating that blood test for at least 3 months. The minimum interval for that blood test is every 3 months. No point doing it weekly, no point doing it every 2 weeks, no point. It's a 3-month fixed number to look at. Those who are using Libras and wearable technology, the beauty of those things is, you wear it for 2 weeks, 10 days, you estimate your HbA1c, but don't forget that estimate is only based on 2 weeks of readings, not the blood test that's based on 3 months of readings. So it's useful, but not as, if that makes sense to you. Healthy diet, I'm not a dietitian, but again, I'm not going to plug on this, but excessive carbohydrates can also cause sugar spikes. You know this more than me, I'm sure. Think careful of food choices you make, the potential consequence of persistent excessive carbohydrate ingestion, for example. Simple things, being well hydrated. A number of people who drink 10, 20 cups of tea and coffee a day dehydrate, heart, kidneys, circulation to feet, it all takes a hit. It's not good. So ideally, being well watered but not flooded. Excessive salt can cause fluid retention, raise blood pressure, stress your heart. Think of reducing the salt, remove it altogether if you can go that far. And caffeine, be aware. Alcohol also makes you pee, don't forget, makes you dehydrate. So in the days running up to surgery, perhaps having a drinking bender, I'm sure you wouldn't, going blitzing alcohol on the day before planned operations, that's not the way to go, I would suggest, in terms of causing dehydration and other chemical wobbles that we don't like. Now, again, you may be waiting for operation because you're in intractable pain, and I appreciate that's difficult. Hence, I never use the word exercise in terms of advice to a person, I talk about physical activity. So being as active as your body permits is to be encouraged. The NHS Live Well website has some tips on chair-based exercise, for example, is something everyone can do, hopefully, to move. So rather than being in bed all day, waiting for your surgery, getting stiff, not trying to do anything, try and avoid that as best you can. Make sure pain relief is good, make sure you can try and move and do something that's realistic for you. It sounds obvious, I know. Take your medications as advised. If you're wondering why after 5-10 years you're still taking drug X or drug Y, question it, ask. Do I still need this drug, doctor? What is it? Ask. Make sure you know exactly what you're taking and how every drug works. It's your body. Please, please don't just accept another pill, another pill, another pill, another injection. Just ask, can I ask what's this for? Just take an interest, really important, because this cocktail of things you take, I'm sure they are all very important, but on occasion we admit people that are on 20 or 30 tablets. You scan the list, 1975, and no one's ever looked at it again and think, why are you still taking? It's really important to take stock periodically, because polypharmacy, the posh medical word for too many drugs, is not good for anybody as well. And again, one of my other frustrations is people on several different diabetes tablets that are not really helping each other, counterintuitive combinations. And there's opportunity there to really streamline, rationalise those sorts of things, particularly if, for example, if, let's say, your HbA1c was sky high and the team said, do you know what, Mr. Jones, really think you need insulin. Starting insulin, though no one wants to do that, I appreciate type 2, if it's a necessary thing to get you across the line, please keep an open mind and recognise that by starting insulin, on occasion, some of the other pills you take can be removed. So a trade-off, if you like. It's highly unlikely you'll do all the same things you're doing before if insulin's introduced. It may happen, but often some things can be removed. Okay? Where are we? So foot care again, terrifies me that a number of people still walk around the house and garden bare feet with diabetes. The only place for bare feet I would say is the bathroom, which sounds really draconian, but if you step on something sharp, you know this, you probably found it hard way, some of you unfortunately, and you cut yourself and it gets infected, trust me, it's a disaster. Unless you're waiting for foot surgery, they're not going to touch you until the infection is 100% gone. They will be very nervous going near you. Worst case scenario, they delay it, the infection ravages gets worse, and you may need to have more extensive surgery than you planned for, which no one wants, particularly in foot, let's say. So mitigating risk from day one is really important. And that also means footwear as well. So just because the latest shop has a pair of trainers for £20, there may be a reason why they're £20, they're not very good quality. So I'm not trying to be a snob, I'm just being really honest. Cheap footwear can be a major risk as well. You could be doing the best foot care at home in the world, you put on some dodgy shoes, all your good work, undone. So be really careful about the shoes you take. You know the advice about always buying shoes late afternoon when your feet are the most puffy, you know this, I'm sure. Think of those sorts of things as well. By all means, tell the person in the shoe shop I have diabetes, just for what it's worth. They won't look at a needle and detect us, they won't do any of that. But just tell them, just so they're aware, okay, he might need wider fitting, or whatever it might be, just think it through. All right? Stress management, yeah, again, sounds really kind of worthy, but it is important. There are many people out there with diabetes who benefit from practicing yoga, deep breathing exercises, meditating. Modern life is stressful, we get that. So doing things that work for you as a person to minimise your personal stress, not popping pills for everything, does matter. And I forgot to put on this list, embarrassingly, good sleep. The importance of a good night's sleep on a regular basis is also really important. There's data that suggests that broken sleep persistently can aggravate sugar levels the next morning, can increase sugary cravings, for example. So give yourself the best chance. Make sure your bedroom is really sorted out for a good night routine. Blackout blinds, a dark room, no telly before you go to, no screens before you go to bed, no caffeine. I mean, you get the idea, the obvious stuff. Sounds obvious, but people still do it and wonder why they can't sleep. So just have a think about all those things you could be doing. If you get sick, God forbid, the leaflet I mentioned, I'm sure other guidance is available. Follow something rather than putting up with it for days on end. Just get in front of things is the idea. Be proactive and get in front of it. Next slide, please. So coming to the end now. So some ideas on a shopping list of things to take with you to hospital. The team may tell you on the ward, if you're really lucky, in the hospital team. It's different in different places, I appreciate. So next slide. So some suggestions for a shopping list that you may not have thought about. What's going to help you in hospital? Some of them are really obvious. Have your up-to-date next of kin information, unless you really don't like them. Make sure they know how to get hold of you, the best phone number. And something I struggle with, so again, someone gets sick, God forbid, a late night phone call is needed to a relative. You open the page, next to the kid, there are about 10 names there. You think, who's who is it? You're not told who it is. So things like obvious, who is the first person you want to call, God forbid, if something doesn't quite go to plan, let's say. I'm not trying to be morbid, just being very honest for you guys to give the best chance to the right person finding out first, for example. Phones and chargers, of course, take a charger. The wards will sometimes have a spare stock of chargers, but it can't be guaranteed. Medications, not because, take your pills, of course. When your doctor admits you, they'll make a documentation so all drugs are prescribed formally on hospital charts, be it on paper or electronic. Please don't pop pills yourself without telling somebody you're doing that. Because as I said earlier, some things are deliberately being suspended and held. Okay? A full drug list is also really helpful. Should, let's say, God forbid, your box of pills you brought in goes walkies. Things do walk on wards, unfortunately. So having a list of meds, be it a piece of paper in your purse, handbag, wallet, or even why not photograph on your phone? Let's embrace technology. Let's take a picture of it. Having your phone, it's always there. And I do the doses as well. For those that wear wearable glucose monitors, that's all fine and well and good, no problem. Just be aware that if you do use that technology, they measure skin fluid glucose, not blood glucose. At the best of times, that data is several minutes behind the blood glucose. If you are sick, ill or dehydrated, that gap can be even longer. So whilst I'm not saying to you can't use them, we're just saying be aware there's limitations, all right? And also the fact that most hospital blood glucose testing machines that we use in the wards, they are networked to a central repository of information. So I can sit in my office, I can open Ward 6, press the button, and I can see everyone's glucose results immediately. If you're using your own home glucose meter, I can't do that. If you're using your Libre or Dexcom device, I can't do that. Whereas if you just let the ward use their machines that they use in the wards all the time, then I can look at it. It's in your interest to let them have a look and let them do that for safety. And see, as I said, to look at banded the glucose data to make sure it's okay. Some people we know like wearing wristbands or lanyards. We're getting the charity, I've got plenty of those on offer today, I believe. I've seen a few around. So please consider wearing that. I have a wristband, I have diabetes, type 1, type 2, whatever you like. Lanyard for some people is helpful. By all means, bring your favourite hypo snacks that work best for you. Of course, the hospital has something available to treat your lows, but if you're very personal, I like having this without hypo, bring it with you. Not a problem. It's all good. That's fine. Equipment-wise, again, the hospital ward should be equipped with various things you need, but it's always good to bring a spare stash of your personal stuff that you like using. If you bring insulin vials in, they can be stored and locked away safely. Your insulin pen, if you've got one that you use and it's working okay, that's fine. And needles, again, as long as they're the right size, etc., that can be used as well. But again, like I said, with insulin particularly, it's making sure that the ward know you're on insulin and it's prescribed. We can't have people open their bag on the slide, jabbing themselves. That's not what we're about, so it must always be prescribed. And again, know which one's called, because there are so many kinds of insulin, the name on that list I mentioned, and the doses is really helpful as well, okay? If you use an insulin pump, you'll need a pump, you need cannulas, you'll need, the pump itself, insulin cartridge, you'll need a handset, batteries, there'll be stuff you need for an insulin pump for a ward patient as well. Slippers, again, hospital where I work provides some sort of special socks, non-slip socks, but again, if you've got your favourite pair of slippers, bring them in. Don't walk on the wards bare feet. Please don't do that. Please, please. And again, old school, notebook and pen. Oh, I forgot to ask that question. Yeah, jot it down for the next wardrobe, and you've got it. Simple. Or on your phone, most phones have got a notebook feature, journal feature, haven't they? Just jot a few things there. Whatever works for you. Just don't be afraid to have some thoughts and write them down, etc. Have I missed anything? Obvious on the list, for those who've been there. Is that pretty comprehensive for most people?
Reading glasses.
Reading glasses, thank you. I knew there was something. There you go. Thank you very much. Anything else? And again, it sounds like a school trick. Maybe put your name on a few things. Because glasses and things do walk, unfortunately. But I'm not going to say false teeth, I'll leave that. But having a name on certain favourite bits of kit is helpful as well. Thank you. Next slide, please. Nearly done. So after surgery, you may find that the things may happen. Your bowels can be a bit sluggish for medical reasons, so you might be fast for a bit longer. They may check your swallowing is okay. We know the food choices, and apologies, the food choice could not have to be the best, but do mention that. Being less physically active after your operation, the days afterwards, the weeks afterwards, can also cause high sugars if you're not burning sugar as petrol, because you're ill, recovering in bed. your sugars may run a bit higher than you're used to. You may be given steroids, as I said earlier. You might be on a feed, again, potentially can cause wobbles. The wound, hopefully, is not infected, being cleaned and dressed regularly. And broken sleep on a ward, I know it's miserable. You get pricked and prodded for blood tests and machines beep. I know it's awful, and I'm sorry. But, you know, that broken sleep, as I mentioned, can cause some disturbed sleep and fatigue in the daytime as well. And foot care, again, making sure the team look after your feet. They check them, make sure there's signs of infections or pressure sores, that sort of thing. Next slide, please. And again, if you're eating and drinking, hopefully you've told your diet, expressed your dietary preferences. You talked about asking for carbohydrate content menus. We offer that in Southampton. Hopefully more hospitals are doing that. You might need insulin drip for a few more days until you can eat and drink enough. And like I said earlier, don't be alarmed if the team suggests you might need to change your diabetes drugs quite radically if the HbA1c is particularly sky high, let's say, for whatever reason. So maybe needing insulin, that sort of thing, because running high for days on end afterwards is a magnet, as I said earlier, for more infections and delayed recovery. Next slide, please. Hopefully, it's time for the Great Escape, like it's for lunch fairly soon, I believe. So planning discharges for patients, we make sure we try and ask teams to plan that from day one to not delay things later on. So it's making sure you guys understand why certain meds were changed or doses were changed. It's making sure you are still okay, or if you're new to insulin, can you do it yourself? Do you feel able to? If you can't, explain you're worried, explain you're concerned, and try and sort out what to do instead. So there are situations where a district nurse can be called out and administer morning doses of insulin for those that really need it, for example. But what I would really urge, somebody asked me earlier about this, what I feel is really important for all of you, if you have to, God forbid, go for surgery or hospital admission for any reason, please feed back the experience. If it was positive, if it was negative, if it was both, please feed it back. Because unless people feed back, nothing changes. I'd love to know we did an amazing job. That's really, thank you, that's lovely. But equally, I'd love to know if things didn't quite go to plan. What was it didn't go to plan, Mr. Smith? But on ward 3, they didn't do the I'd love to know that. I can go to ward 3 and say, why is it this guy was in last week, but this guy on? We're really sorry, we know about that, we'll change up. Do you see what I mean? Without knowing, we can't change things. So please be vocal and be active participants in your diabetes and communicate when you feel ready, the good, the bad, and the ugly, dare I say it. Whatever you need to feel you need to do, please say something. Next slide, please. So to conclude, I hope I've outlined for you how being in Mission Hospital can be stressful, both physically and mentally for some people. There's things you can do in the immediate weeks and months before and after to make sure diabetes is not going off the boil and stays in check. And sometimes needing surgery can be the kick people need to make real positive, lasting lifestyle changes to support living well with diabetes, for example. The right kit on the ward, like I said, is really important. Please don't leave without unanswered questions, particularly linked to diabetes and how things have changed radically. Make sure you ask for advice on why am I on this drug, why am I on that drug, why was that drug stopped. Please ask, it's really important. You know that. And as I said, please feed back either way. Next slide, please. So to conclude, I hope that's mission accomplished, and I'll very happily take any questions. Thank you for listening. Hello.
I'll stand up from the front so those at the back won't hear.
Far away.
Yes, I'm particularly interested in this 69 mmol.
HbA1c level, yes.
Yes, HbA1. Having had advice that I needed my knee replaced, I decided to go off on holiday in my motorhome for a month. And what do you do when you're on holiday? You have a few more treats, right?
That's what holiday's for.
No, nobody at any stage during my consultations mentioned the national aim level of 69. So of course when I went for my pre-op assessment after having this jaunt, it was 71,
okay.
And they cancelled the operation. Why, my question is, why, if it's a national aim, doesn't it appear in any of the diabetes literature?
That's a very good point. I mean, again, I can't vouch for how many communication is shared in every hospital in the country. I'm sorry, like I said earlier, I can tell you we do it in Southampton, but I can't tell how it's conveyed elsewhere. It should have been, you're right. And maybe that's it to feed back to the team. Then
I have fed it back to the Diabetic Association.
No, to the hospital. To the team who operates on you.
Yeah, but I did feed it back to the Diabetic Association, and their comment was, well, the levels are different, whichever hospital you go into.
The aspiration is 69, as I said,
Yes,
69,
but
70.
that should be very clear, because I must confess I was absolutely ignorant about
Apologies.
the level being so
Yeah.
effective of the operations.
Yeah.
You know.
So that, like I said, I can't speak to the whole country. But I definitely please feed it back to the team rather than Diabetes Association. Tell the hospital team.
But the Diabetic Association should have.
No, but they can do something. That won't be more. Your patient voice is way more powerful. Trust me. In that context, for an individual hospital, because you've been there and been through it. Trust me.
I wonder how many other people have found
Maybe quite a few, unfortunately. But thank you for your question. That's a good point. Thank you. Hi.
Hi. I'm on,
Shout away. Go on.
I used to be a lecturer, so I can do the
All right.
I'm on dapagliflozin.
Yeah.
And you said about if you're on insulin and you were going towards DKA,
Yeah.
that you'd mess around with the insulin. What happens if you're on DAPA? Because I think the start of DKA a few months ago,
Okay.
and I'm on a low-carb diet, which is really helping my blood.
Okay, so thanks, good point. So dapagliflozin routine in the UK should be suspended for a minimum of 2 days before planned surgery.
Right.
That's what should happen.
Okay.
With carbohydrates, though you may have a low carbohydrate diet, which is great,
Yeah.
it's making sure the low carb number is not less than 50 grams a day.
No. I'm 70
We all need 50 grams as a minimum to prevent fat burning and ketones.
Right.
Okay, so the flozin effect, though you stopped it 2 days before,
Yeah.
could still be doing something internally for a bit longer. So what should happen is after surgery,
Right.
your ketones should be checked daily.
Right.
That's what should happen.
Yeah.
But again, it's not, I can speak for Southampton, can't speak for the whole of the UK, but it's a sort of feedback, it wasn't done for you.
No.
Yeah.
It
Yeah.
was just, I just thought, nobody had, again, this communication
Yeah.
thing, nobody communicated about this keeping above the 50-gram threshold. I
Yeah.
have been,
Yeah.
but I think perhaps when I was feeling poorly, I perhaps wasn't at that point.
Exactly, and as I said, that's your low carb before you went to hospital and had the operation, whatever it was, and the flozin effect is still hanging about a little bit, like that cocktail of things, I thought maybe just tipped you over,
Yeah.
unfortunately.
It's a great drug apart from that.
Yeah, and a well person, like I said, well people,
Yeah.
great, thank you. Any more? Yes, madam.
If you find yourself overseas and you have to have a hospital.
Overseas?
Yes.
Either way you mean, or around?
There is been. And you find yourself needing a hospital admission.
Yeah.
Is it best that you yourself try and liaise with your own medical team in the UK? Or?
Depending where it is, as you know, worldwide healthcare systems are very different. So I didn't mention it, I'll be honest, health insurance. Definitely have health insurance. If you're in a state where something major can be flown back and your insurance covers it, I personally would push for that. If you had anxiety about where you were in the world, this healthcare system is not quite where I'd be comfortable. And if you were safe to transfer you back to the UK, that's what I push for. But everyone's case is different. Phoning the UK is not really going to do very much, I don't think, because it's going to be a quagmire of bureaucracy and so, well, I can't hear you, where are you? I can just imagine it's just not going to land well. When someone's in a different hospital, you respect the hospital's ability to manage things. They might phone us for advice on, we've got Doris here from the UK, You know, that doesn't happen, that's never happened to me. I'm sure colleagues have happened to, but it's going to be rare, I suspect. I think being planned, good insurance, and if you're safe to fly back, I would encourage fly back. All right?
Gonna have to wrap up.
Sorry,
now,
guys.
No,
Yes, sorry.
no. All the lunch will be gone. That's
Oh,
what
no,
I'm worried about.
don't do that, no.
Just to say,
You fasted at 45 minutes, you fasted, it's fine, you can be fair now. Thank you.
thank you very much, Mike, for a very informative talk as usual. Certainly there's a few pointers for me there. So,
Thank you all, take care. Thank you.